Okay, so let us proceed. Again, now we are talking about the factors that can influence the circulating concentration of an orally administered drug. Another factor is elimination by hepatic metabolism. So again, no, don't forget that we're doing this to ensure that a given drug dose is within the therapeutic range, so as to maximize the therapeutic effect, whether you're giving a cardioactive drug, anti-epileptic drug, psychoactive, immunosuppressive, or anti-neoplastic drug. So regarding elimination by hepatic metabolism, remember that all substances absorbed from the intestine enter the hepatic portal system for first pass metabolism before it can before the drug could enter the circulation. So just remember now how is your bilirubin metabolized. So as the drug enters the sinusoids, it would be transported into the hepatocytes for first pass metabolism. Liver metabolism may vary in every patient and is influenced by genetic variation, since there's also a variation in the rate of hepatic and non-hepatic drug metabolism per person, and diseases. If you have a fatty or cirrhotic liver, this could reduce the capacity of the liver to metabolize drugs into a therapeutically active metabolite. So again, no, don't forget that we're talking about another factor, elimination via hepatic metabolism. So the hepatic mixed function oxidase or MFO system is actually responsible for a large portion of drug metabolism. And that's by converting the hydrophobic substance, the drug, usually no, through the action of various enzymes, into a water-soluble substance, eventually no, eliminated via the bile or released back into the circulation for elimination by renal filtration. So as you can see, no, the drug here is transported into the hepatocyte. It will be acted upon by the hepatic mixed function oxidase, and the product is either drained through the biliary tract or transported back into the circulation for elimination by renal filtration. The MFO system usually has two phases. We have the phase 1, reactions, which produces the reactive intermediates. Like for example, no, the acetaminophen or the paracetamol, it is reacted by the cytochrome P450 enzymes to metabolize it into an acetyl benzoquinonamine. So that's it, no? But it's a reactive intermediate. The phase 2 reaction, on the other hand, here the functional group like glutathione is conjugated into the reactive intermediate. Okay? And in this case, no, since it's paracetamol, it would eventually metabolize into a mercapturic acid. So again, this is just an example on how the hepatic mixed function oxidase system metabolizes a therapeutic drug. In this case, no, acetaminophen or paracetamol overdose may lead to irreversible damage to hepatocytes since of the excessive substrates may lead to the excessive formation of reactive intermediates that could cause the liver damage. Don't forget that hepatic MFO system is inducible, which means it increases in synthesis and activity with the presence of synabiotics such as the drugs. Competitive and non-competitive interactions may also occur. That is with the presence of other drugs or other food like grapefruit and beverage containing alcohol and caffeine. Like for example, no, in the case of acetaminophen and alcohol consumption, the alcohol may impair the liver function, So thus more reactive intermediate may be produced out of the acetaminophen. So it's like overwhelming the conjugating capacity of the liver, similar to your bilirubin on how it's being metabolized. So that's it. No, that's the other factor that could affect the circulating free drug, and that is by elimination through metabolism. Another factor is by elimination through renal excretion. So remember now that hepatic metabolism and renal filtration, or the combination of the two, eliminates most of the drugs. As you can see, the liver may eliminate the drug via biliary elimination through the stool, or through the liver via renal elimination through the urine. The plasma-free fraction of the parent drug or its metabolites is subjected to by the kidney through glomerular filtration. A decrease in the glomerular filtration rate will directly increase serum half-life and concentration of the drug. And another one is through renal secretion, by which for drugs that are not secreted or reabsorbed, the elimination rate would be directly related to the glomerular filtration rate. By the way, a decrease in the serum concentration of drugs often occur as a first-order process or exponential rate of loss. As you can see here in figure 3, the plasma concentration of the drug is exponential, 0.1, 1, 10, 100, 1000. And if you look at the time after the time and the elimination rate, the higher drug concentration, with a high drug concentration, usually the decrease is also large, but as the drug concentration lowers, so as the elimination also becomes smaller. So that's it, it's exponential. And usually it's represented by this formula. The change in concentration per unit of time of the therapeutic drug is directly related to the concentration of the drug and the rate of elimination. So it's negative because the rate of elimination is decreasing. So don't forget that this figure 2 represents the rate or percent loss remains the same. Though, if you are to present this using a semi-logarithmic plot in figure 3, you can see indeed that with high drug concentrations, there's a large decrease, but with low drug concentrations, there is a smaller decrease. But again, don't forget that the rate percent lost remains the same, though it's logarithmic. Okay, so that's it. Now that's how the kidneys eliminate most of the drugs. So that's it. That's another factor affecting the concentration of circulating free drug, and that is by elimination through renal excretion. And don't forget that our goal here is to maintain the drug in its therapeutic range. Okay? So again, regardless if it's a cardioactive drug, anti-epileptic, psychoactive, immunosuppressive drug, anti-neoplastic drug, we are trying to maintain them in a certain circulating free drug levels, so that to ensure a maximum therapeutic effect of the therapeutic drug, and so that it will not be affected regardless of your age, sex, genetics, or your altered physiologic condition of your liver or your kidney. Okay, so we are done discussing the factors. Now let's proceed to the discussion of your pharmacokinetics and pharmacodynamics. Okay. In pharmacokinetics, the activity of a drug in the body, again, is influenced by absorption, distribution, serum protein binding, metabolism, and elimination by renal excretion or liver metabolism. So as you can see in this figure, number 3, it's a plot of elimination after an intravenous administration of the drug. The figure 3 assumes that there is no distribution of this drug and that they are only confined in the circulation, which means that the rate of elimination is linear through renal filtration. On the other hand, this figure 4, after this one again is a plot of elimination after an intravenous administration. The figure 4 assumes that a drug is distributed outside the vascular space. So from the circulation, it's distributed into the interstitial cavities and into the intracellular spaces. And here, if you look at it, the rapid rate of decrease as seen immediately after the IV administration of the drug, this immediate decrease is a result of both the distribution and the elimination. So since there is a rapid rate of decrease in the first hour of administration, the rate of elimination can only be then determined only after the distribution has been completed. So that's it, no? That's when we usually determine for the concentration of the circulating free drug. This figure, on the other hand, is a plot of serum concentration after administration of a drug, no? So it's oral. So as absorbed drug enters the circulation, it is subjected to simultaneous distribution into the cells, into the cavities, as well as elimination through renal filtration. So here's another figure of the absorption phase and the post-absorption phase. So the serum concentration of the drug would only rise when the rate of absorption through oral administration exceeds that of the distribution into the cells and into the body cavities and through elimination by renal filtration. But the serum concentration would now decline if the rate of elimination and distribution exceeds that of the absorption, usually not through the GI tract or GI absorption. So with this, the rate of elimination can only be determined after absorption and distribution are complete. That is with the oral administration of the drug. Okay, though most drugs are delivered on a multiple dosage regimen, like for example, once every 8 hours, once every 4 hours. So it's not just only once. So this is until the serum concentration of a drug oscillates between a maximum or peak drug level and a minimum or true drug level. So that's when it oscillates within what we call the therapeutic range. Again, usually we maintain this for days to weeks until the drug reaches its target site. Now, like for example, the cardioactive drug reaching the myocytes or the hepatic drug reaching the hepatocytes. So they should be maintained in their therapeutic range for a certain period of time. So approximately 5 to 7 doses are required before a steady state oscillation is acquired. Kasi sabi nga natin, below or above the therapeutic range may lead to inefficacy or toxicity. So that's why they should only be within the therapeutic range. So once the steady state is established, that's when now we determine for the peak and the true concentrations of the therapeutic drug. So that's it for the pharmacokinetics, which explains the other factors when to determine for the concentration of the circulating free drug. Okay? For the pharmacodynamics and sample collection, that will be discussed in the next video.